Hi, I'm Deborah Sims. I'm a CLL patient from Melbourne in Australia, and I'm reporting from ASH for Leukaemia Care in the United Kingdom. And I'm joined by Dr. Bill Wierda from MD Anderson and Dr. Barbara Eichorst from the University of Cologne. Thank you very much for joining me. We've had day one of the conference today. I have to say I've run from session to session. There has been so much on CLL and so much has changed since the European Hematology Association meeting only 5 months ago. What for you today was your take home of the new developments from the latest trial info?
Well, today we heard a lot of updates from trials that we heard about last year. For example, the ibrutinib venetoclax trial that we had presented last year, which was an early report, was represented at this meeting and was a little bit more mature. We have more patients who've had the combination for a longer period of time, and we have a better idea and more confidence in the response rates that we are seeing that we reported earlier.
And this was untreated patients,
This is previously untreated patients. So today the presentations, at least the data that we presented from MD Anderson, were 2 trials, ibrutinib venetoclax for untreated patients over 65 or younger patients who have an unmutated immunoglobulin gene or 17p deletion. The other trial was IFCG, which is a chemoimmunotherapy-based treatment, which was only for patients who are fit and have a mutated immunoglobulin gene. So those data are more mature now, and we have more confidence around the response rates that we're seeing, the high response rates that we're seeing, and the depth of remissions that we're seeing with regard to testing for minimal residual disease.
And it shows that depth of remission that I found really interesting, that we're talking about undetectable minimum residual disease at different levels, UMRD4 and UMRD6, and that this has become really an endpoint treatment so that we can have these finite treatments to take patients to the same depth of remission that FCR was giving the right section of patients, but without them having chemo. I mean, what did you think of what we were hearing today?
Yeah, besides the trials Bill mentioned already, there was also the British trial also evaluating the ibrutinib venetoclax combination, but in relapse situation. And even in those patients in relapse situation, there were 39% who were MRD negative or undetectable MRD in the bone marrow after 1 year of treatment. I mean, this is something we have never observed with chemoimmunotherapy before in this situation. So this shows also how effective these combination therapies are. And also, as John Seymour, he showed data from a trial treating one part of the patients with BR, the other one with venetoclax rituximab. And there we were able to see the same, that those patients who do not have any detectable residual disease in a relapse situation, they have an extremely long progression-free survival. So these are really very encouraging data.
I thought, particularly with that trial, the Murano trial, I thought it was really interesting that there were 2 patients that had been able to come off treatment, had relapsed after more than 24 months off treatment, but then had had another response when they'd resumed taking venetoclax again. So is this something you think will become part of the treatment paradigm, is that we will have intense periods of treatment, maybe with ibrutinib venetoclax and a monoclonal antibody for whatever, up to 12 months, and then we will have long periods of remission?
That's the paradigm, and that's the strategy we're moving towards. We were sort of going in that direction when we had chemoimmunotherapy. With the chemoimmunotherapy combinations like FCR, we were getting deep remissions, not as deep as we're getting now with the small molecule inhibitors, but we were getting deep remissions, and that had started the conversation about MRD and MRD as an endpoint and how undetectable MRD correlates with a longer remission period. And then along came ibrutinib, and patients weren't going into deep remissions, but it was very effective and very effective for relapse. And that conversation about MRD as an endpoint sort of went to the sideline. And now, as we come into this new era where we have venetoclax, which is very potent at getting rid of leukemia, and we're looking at the combinations, the discussion about MRD and undetectable MRD as an endpoint has really risen to the very surface of what we're doing and what our endpoints for treatment are.
One thing I thought was interesting today that Jennifer Brown was talking about in the relapsed and refractory setting was that there's now an unmet need for patients who start failing a BTK inhibitor or BCL2 inhibitor, that we're sort of, once you've failed a novel therapy and there's only, you go to another novel therapy, that then we're having to look at what's next for those patients. Is that becoming more of an issue in clinical practice?
Yes, unfortunately is that the more patients receive usually first ibrutinib, and then after ibrutinib failure of venetoclax, the more patients we see. I think what we also learned is that when ibrutinib went from the trials into the clinical practice, that because of the side effect profile, which is very excellent, but when patients have to take their drug every day for years and years, of course also mild side effects might become a reason for stopping the treatment. And therefore I think what we also learn now, that we should really be cautious before we change to a completely different drug, just because of side effects. Of course, for patients, mild side effects might really cause problems in his daily life when diarrhea occurs and so on. But I think we shouldn't change too early to the novel treatment, to the next novel treatment, in order to have a big variety of different treatment options still open.
Well, Professor Halleck obviously today gave the keynote address, which was wonderful to see CLL, someone who's worked in the field for so long, being honoured in that way. And he was talking about resistance to actually trying to identify the mechanisms that are developing resistance to these molecules. Can you tell us a little bit more about that?
Yeah, so he showed data from our clinic where we had evaluated 8 patients with 17p deletion in relapse situations, or the poorest prognostic patients. And those patients were treated in a phase 2 trial with venetoclax, and those 8 patients after a while became progressive. And we looked at the genetic profile of those patients, and what we can see is that probably progression with venetoclax is a more complicated mechanism, because in comparison to ibrutinib, where we see that the gene which is coding for the BTK, for the Bruton's tyrosine kinase, is in 50% mutated. In venetoclax, we don't see that a typical pattern. There is a paper now at ASH showing also this pattern. What we have seen in Cologne is that there are different mutations which can be detected. And the idea is that also with the technical methods we have now today available, that we maybe should screen patients as soon as we see that either they're relapsing, or also by routine if they have residual CLL cells, and when we can detect a mutation, trying to address that mutation.
We haven't. Tomorrow will be more about CAR-T than today, but obviously that is something that's very exciting. There are a lot of papers here. It's something you're both involved with. Can you tell us what we're expecting to hear from the conference over the next few days on CAR-T? Sure.
So the CAR-Ts have been in development for quite a while, actually, for CLL, as well as for other B-cell malignancies like diffuse large B-cell lymphoma and ALL. Unfortunately, the response rates, and particularly the complete remission rate, has been lower for patients with CLL compared to those other diseases. And probably the reason for that is the immune system doesn't work normally in patients with CLL, and the CLL cells themselves can affect T cells and make them not work as well. And that's probably why these cells are not working, the CAR-T cells are not working as well in patients with CLL. The data that we're going to hear about at this meeting is ways that we can enhance the function of T cells, perhaps by treating patients with CAR-T cells while they're on ibrutinib, making a product from cells that are collected, T cells that are collected from a patient who's already on ibrutinib, and some other ways to manipulate the production and what we do when we're treating patients with the CAR-Ts that enhances the response rates that we're seeing.
Would there be an argument for T cells to be harvested from patients who have high-risk disease early in the disease?
There's that aspect, but the T cells are still dysfunctional. Even in patients who haven't had any treatment, their T cells are dysfunctional. So I'm not sure that that's necessarily the answer. I think it's more making the T cells work better when they're in the patient and they're there to eliminate the leukemia cells. I'm particularly enthusiastic about the immune system and immune cells as perhaps the next step to curing the disease. And the reason for that is that patients who have received an allogeneic stem cell transplant, those patients can have very long remissions and are potentially cured from their disease. So it speaks to the fact that there's something different about the immune system, if it works, that can eliminate leukemia there, that is a different mechanism and perhaps complementary to the things that we have now available, the small molecule inhibitors, the BTK inhibitors, and venetoclax.
I mean, the C word, the cure, I've heard that mentioned a few times today, and that's because we're getting deeper into the biology than we've ever been before. How close do you think we are to you being out of a job?
I mean, there is maybe already right now a minority of patients who may already be cured, but these are the fit patients who have only favorable prognostic factors in their genetics, as a mutated IGVH status in a certain QT lesion, for example, and we see that the overall survival curve is flat on the top, and so maybe some of those patients are already cured, but unfortunately this is at the time point when patients need treatment, this is a minority of the patients. So the hope is with the novel combinations at the IV combination that we are also able in patients with more unfavorable prognostic factors to achieve these eradication of all the residual CLL counts, or at least to such a low level that the immune system is able to control the rest of the residual CLL cells, because we know that also in the normal population 2% of the people increasing with the age are carrying these CLL-like cells, and so obviously if the immune system is able to control some residual CLL cells, everything is fine.
I think we're close to cure. I think it'll happen in my career lifetime, I think. So I'm very enthusiastic and very excited about that prospect. Patients will still get CLL, so we'll still be treating them. And there are other features about the disease that we know less about that we really need to focus our work on. Things like immune dysfunction that we see in patients with CLL, risk for second cancers or other cancers that are occurring at higher frequency among patients with CLL. Patients who we have now that are doing well on the small molecule inhibitors, long-term treatment with ibrutinib, venetoclax, the biggest risk for them right now isn't necessarily their CLL, it's developing a second cancer or developing some type of infection while they're on treatment. We have very good ways to control the disease, but there's other things that are happening that deserve our attention that we are intending to focus on as well.
Thank you both very much. Enjoy the rest of ASH, and on behalf of patients, thank you for all you're doing for us.
Thank you.